Hello and welcome to the Oxygen Medications and Transport lecture in perinatology. So we'll be covering a lot of stuff here. So do understand this can be pretty involved, but overall, just try to take it one step at a time, and you can always rewind and go back over this. A lot of this stuff should be from your book, and understand different hospitals will have different policies and procedures on when to administer certain types of oxygen, different types of medications, and then even different transport companies might have different ways of saying a patient is ready or not for transport. So pay close attention to that when you're out there as well. So what are our goals? Goals with oxygen is to achieve adequate tissue oxygenation, right? That's that first thing on there. So how do I know tissue oxygenation on this? Well, one of the things you have to be careful of when we look at a newborn is that for that first 3 to 6 months or so, they have fetal hemoglobin, which means they're left shifted, which means they're going to have higher saturations on lower PaO2s. That's how they survived in utero. They were able to attach themselves and carry a lot of oxygen with low PaO2s. Well, that's what they still have left over going on as a newborn. So just because their saturation looks good doesn't mean their ability to oxygenate their tissues are good, because even if someone's left shifted, the hemoglobin's holding on to the oxygen, but it's not letting it go to the tissues. So how do we know? Well, we got to look at their PaO2 on an arterial blood gas. So if there's any reason why a kid's becoming acidotic, or why they start to show signs of cyanosis or anything else like that's going on, we need to check an arterial blood gas to look at PaO2, not just saturation, because they are automatically left shifted on their curve. So look at that. The other thing is making sure when we use oxygen, we use what's appropriate to their size, gestational, postnatal stage, right, in their clinical condition. You're not going to put a nasal cannula on a kid that's not breathing, right? It doesn't make sense just to do something low flow and just put it on a kid that's not breathing. And same thing, you're not going to start bagging a kid that's breathing just fine and their saturation is just a little low. So you're just going to put some light nasal cannula on them. So make sure you use what's appropriate for those kids. And even their saturation goals, as we've talked about in other videos and in class, their saturation goals will vary depending on how far along in gestation those kids are. Your preterms, your micro preterm or extreme preterms, they're easily going to have that 85 to 92% goal. In some cases, in term kids, could be up to 95 to 98% without having issues. So know your saturation goals for each baby, right? Make sure you have the appropriate goals for the size of those kids. Adverse reactions from the use of oxygen are well documented in neonatal and pediatric patients. Stevie Wonder, the singer, was a case of retinopathy of prematurity. They gave him too much oxygen, and his retinas eventually detached, and he became blind, right? And that's us. That's not something that we want to have happen to our kids. Now, ultimately, the oxygen stress that could cause that is more noted in your preterm babies. It's more likely to happen in preterm versus term kids. So oxidative injury is more prominent in preterm babies than in term babies. But oxygen therapy, this last point here, needs to be provided at an accurate and safe level with the lowest possible FiO2. Lowest possible FiO2, right? That's not a mistake. So the whole thing there, and that's why you'll see a lot of kids in the NICU be on room air on a ventilator. It'll be 0.21 or 21%. Or you'll see them on a CPAP machine and they'll be on 21%. Or you'll see them on a high flow at 21%. So most of the time they just need that ventilatory assistance and not necessarily the oxygen assistance. So try to keep them on the lowest FiO2 possible that is safe for that patient. What about cardiac physiology? Well, with cardiac physiology, the circulatory system might be unable to provide adequate tissue oxygen. In other words, we're not perfusing appropriately, right? So if they have a slow heart rate with bradycardia, if they have heart failure, hypotension, hypothermia, all those things will cause either poor cardiac, secondary to cardiac performance, or vascular performance. So this goes back to the whole VQ match thing, right? When we have the ventilation versus the perfusion, right? Alveolar ventilation could be decreased or perfusion could be decreased, right? Those things would cause hypoxemia and other issues. So bradycardia would be a low perfusion. Cardiac failure would be low perfusion, hypotension, low perfusion, hypothermia, vasoconstriction, which means low perfusion, right? So things like that could be pretty significant. So is there hypoxemia secondary to perfusion issue, or is it secondary to a ventilation issue? If it's secondary to ventilation, then fix the ventilation. If it's secondary to this perfusion thing, well, fix perfusion. Cyanide poisoning is something you have to be careful of. We're not talking about newborns just out of the birthing process. We're talking about a little bit older infants here, but cyanide poisoning usually means the tissue is unable to accept and use oxygen despite how much you're getting it there. And so this is where we went to our hack: histotoxic, anemic, circulatory hypoxic hypoxemia. Low ventilation would be hypoxic hypoxemia. Now, the histotoxic, which would be the toxin, would be a form of cyanide poisoning. Cyanide poisoning would be included in that category. So what we're looking at there is they have poor, they have the tissue that can't accept the oxygen, but we're able to give them as much oxygen as possible. It's just that the tissue won't be able to process that oxygen. So that's something to look for too. How will you notice this person's having? Well, they have adequate PO2s, they have adequate perfusion, they have adequate ventilation, but their organs are shutting down, very similar to the sign, the carbon monoxide poisoning and the anemia, right? Except where they'll have normal red blood cells, they're going to have this issue, and you're going to see that multi-organ system failure start to kick in because the tissues aren't getting the right amount of oxygen. So how do we document hypoxemia? ABG and pulse oximetry are going to be your two ones. Remember, the pulse ox is the number one monitor used in the neonatal intensive care unit. So the most definitive evidence of actual impending tissue hypoxemia will be usually indicated by arterial blood gas or pulse oximetry. Understand this, that arterial blood gas can include co-oximetry. Co-oximetry looks at all the different kinds of hemoglobin. It looks at fetal hemoglobin, it looks at methemoglobin, it looks at carboxyhemoglobin. It looks at all the different kinds of hemoglobin, sickle cell. It looks at all the different kinds of hemoglobin and will give you levels, so that way you know if you have a dysfunctional hemoglobin that is there. So if there is carbon monoxide poisoning, it would show up on your carboxyhemoglobin. If you have methemoglobin from lidocaine toxicity, it would show up there and you would see it right away, right? So those are ways to also check as well. All right, some definitions. So children with a PO2 less than 80 or SAT less than 95 usually indicate hypoxemia. Notice that this is at sea level, right? So if you're practicing in a place like Colorado where there's a higher altitude, then understand you're going to be a little bit lower than that, just based upon your barometric pressure being lower and therefore lower oxygen levels subsequently. So practice is to only treat a pulse ox less than 90% or a PO2 less than 60 millimeters of mercury. Remember the oxyhemoglobin curve? I know you do. You're like, there's not a day goes by that I don't remember the oxyhemoglobin curve, Derek, right? So with the oxyhemoglobin curve, a PO2 in the 60s should mean a saturation in the 90s, right? So if you remember that curve, that's why we try to get that PO2 greater than 60. So that usually means that their ability to maintain good oxygen carrying is intact. So that's why a PO2 in the 60s is perfect, right? If we're looking at pressure. If we have fetal hemoglobin, which most of our newborns do, that means it creates a left shift on the curve, which means this safety zone up here where their sats are greater than 90 is moving to the left, which means they'll have a higher saturation for a much lower pressure, right? That's not a good thing because that means their PO2s are lower, which means their ability to get oxygen into their tissue decreases, right? So we'll have a high saturation for a low PO2, right? So in the postnatal stage, a PO2 of 50 to 60 usually corresponds to a sat of 85 to 90%, which is decent in most newborns, especially your pretermers. But a PO2 less than 50, notice this is in bold, a PO2 less than 50 or sat less than 88% in the newborn, and this is according to sea level, indicate hypoxemia and might necessitate oxygen therapy. So understand, if you see those values 88% or less or a PO2 of 50 or less, that would indicate administering oxygen therapy of some kind. So what are some signs and symptoms? So the earliest clinical manifestations of hypoxemia, notice it doesn't say cyanosis. Notice it doesn't say cyanosis. Once again, notice it doesn't say cyanosis. It says tachycardia and tachypnea. So they're breathing fast and their heart rate's fast. Okay, that is very bland. Are there a number of other things? Can you stressing out the baby cause their heart rate and the respiratory rate to go up? Of course. Can pain? Yes. Can them being hungry? Yes. Right. All those things could cause that. Right. And more, much more. Right. So the big thing here is looking at these patients carefully. If they're suddenly developing more tachycardia, more respiratory rates starting to go up, then that we need to pay attention. What are some reasons for this, and start ruling out some causes? Because if that starts to happen, they're going to progress into hypoventilation, right? They're going to tire out. When they tire out, they'll start not breathing. That's the apnea. If they stop breathing, well, that's when the bradycardia will kick in. So those are all bad things, and we want to be able to catch this early. Other signs that we'll see, of course, expiratory grunting, like what we talk about with COPDers in the later stages, or even those newborns that have a lot of retained fetal lung fluid and they might need a little bit of positive airway pressure for a little while. Nasal flaring, very common. You'll see nasal flaring. Like, look out for this when you're at the NICU clinicals. And you'll even see nasal flaring on your adult intubated patients. If they're working hard to breathe on a ventilator, you could easily see nasal flaring on those adult patients. Retractions, of course, paradoxical breathing where their belly and their chest wall are not in sync with each other. Cyanosis is a late grave sign. Did you hear what I just said? Cyanosis is a late grave sign. So if you see cyanosis on a kid, it's been going on for quite a while. And we're not talking about transition at delivery, right? We're talking about a kid that's post-delivery, right? If a baby's irritable, that could easily be another sign. Of course, that's a non-specific sign. They could be irritable for a number of other reasons. And same thing with restlessness. Now, something to pay really close attention to here, and we've talked about this a lot, is becoming lethargic and flaccid, right? So if they have their tone that leaves them, that's a very bad sign. We've talked about this at delivery ad nauseum. So you already know that's a bad sign, and that could be a early sign and symptom of hypoxemia. Cyanosis, somewhat useful in the pediatric and adult infants. We can see it pediatric and adults, but in infants, it is a late sign. Notice this is something I just said a little bit ago and repeated it. A late sign of severe hypoxemia. So if you see a kid post-delivery, right, if you see a kid that's cyanotic, then you need to be careful. That's something that has been going on for quite a while. Acrocyanosis. When we see this, this is where the fingers and the toes, the hands and the feet, right? Those things start vasoconstricting, or they start turning purple, or they are purple. So if your body temp decreases, right? So if you become cold, right? If your body temp decreases and you become cold, you remember how you blow into your hands, right, to warm them up, right? So when your body temperature decreases, your peripheral circulation, right, or your peripheral circulation will have vasoconstriction because it's so cold. So when we have this, body temperature decreases, we'll have a decrease in circulation, and because they're vasoconstricted, they're cold. So is this baby cold? Could that be one of the things that's causing their acrocyanosis? Central cyanosis, bad sign. That especially when we're looking at these kids, it's a late grave sign. But warm and well-perfused areas of the tongue and mucous membranes are usually some of the first signs that you can look for to see if a kid has central cyanosis. So look at their gums, right? Look at their tongue. Look at all the mucous membranes in their mouth to look for central cyanosis. If a baby has HbF, right, if we're checking co-oximetry, that means their PaO2 can be low before their deoxyhemoglobin is present. So that's another reason why we might not see cyanosis until a late grave sign, right? Because of this fetal hemoglobin, cyanosis is a late grave sign. Unlike the adults who don't usually have fetal hemoglobin anymore, that will be one of the first signs you'll see on an adult. Central cyanosis, if you do see their gums or their tongue or anything like that that's gray, pale, purplish, right, that cyanotic appearance, usually means that if you see that, their delivery of oxygen to their tissues is very insufficient. In other words, they could be going into a metabolic acidosis because they're not delivering enough oxygen for the metabolic system to keep up. So cyanosis is an unreliable indicator of how bad the hypoxemia is in infants. So in other words, we should catch it hopefully before we see cyanosis, and that's where we'd need to do arterial blood gas monitoring or pulse ox monitoring. So what are some complications when we do give oxygen? Sometimes in the neonate population, this can be pretty severe, as we've already talked about. When we're looking at these babies, where the normal response to ventilation is blunted and because of chronic hypercarbia. So if we see these kids that have chronic respiratory diseases, bronchopulmonary dysplasia, cystic fibrosis, their ability to ventilate is going to be poor and they'll have chronic hypercarbia. So that could be something that is going to limit our ability to get oxygen to there. And so if we do have, especially on these preterm kids, abrupt and excessive increases in oxygen, it can actually decrease the respiratory drive a bit and result in hypoventilation and cause a respiratory acidosis. So with babies, when you're giving oxygen, take baby steps, right? Small changes in FiO2, small changes in delivery systems, right? Oxygen should be initiated at low FiO2s and increased based upon their PO2 and saturation. So that comes back to what we talk about with NRP. Where do you start your resuscitation at? What FiO2, right? You know the answer to that. We usually start at room air to 30%, right? So we got to start low. We got to make sure we titrate to effect. Because one of the things that you could eventually develop is what's called retinopathy of prematurity, right? This means there's a constriction of the retinal and cerebral vessels in the neonates that can lead to ischemia, right? That's right, ischemia, right? Which means they could have retinal scarring or even retinal detachment. That would be blindness, right? Retinal detachment. So there is procedures we can do if we start to see ROP on these infants to help stop them from retinal detachment, but hopefully we won't get there. So try to avoid excessive PO2s on your baby. Some complications of ROP. The cool thing is here, it might resolve spontaneously. That's really cool, but it could also result in permanent visual impairment, including blindness. So I want you to be careful on this. Could you be part of a team that could have this happen to a patient? Absolutely, and I want you to avoid being part of that. Other things that have been correlated, not caused, but correlated with ROP include their risk of brain bleed, intraventricular hemorrhage, and then things like sepsis and low birth weight are all things that we have to factor in as well. if we keep on giving this patient too much oxygen, hyperoxia, that could favor the progression of ROP. So in other words, keep hitting that 100% O2 button, right? Keep hitting it, right? You're causing harm, right? What's the Hippocratic Oath? First, do no harm, right? So make sure that you're taking baby steps with babies, right? The big thing is to target a SAT. 88 to 95 on most babies should be appropriate. PO2 anywhere between 50 and 80, especially infants less than 1,500 grams. Those are going to be good target levels to go by in general until the care team decides they want different target levels. High FiO2, obviously we know it's been linked to atelectasis, causes pulmonary vasodilation, which could easily cause a shunting effect, right? Because now you have more perfusion than ventilation. And then even things like pulmonary fibrosis with oxidative lung injury, because with high FiO2s, what happens to your production of surfactant? It decreases. Right? So those are things that you got to be very concerned about. So you could be causing harm by giving them too much oxygen. All right, how do we do it? So there's a lot of different devices. They vary based on the rate and depth of breathing, how much FiO2 or delivered oxygen you're doing. So that's the FDO2. So if you haven't heard that before, FDO2 is the fraction of delivered oxygen. So if we're giving this baby low flow nasal cannulas, we're giving a 64th of a liter, right, or 1/32nd of a liter, right, super low flows. The FiO2, or how much FiO2 the baby's inhaling, is going to vary depending on the prong to nair size, as well as if the baby is breathing at all or entraining at all through their mouth, things like that. Trach adapter, simple mask, non-rebreathing mask. It depends on those older kids, obviously, with those. A device that can meet or exceeds their inspiratory flow rate is usually not affected by their breathing pattern, right? So if I give this baby a high flow nasal cannula at 6 liters per minute or 8 liters per minute, that heated high flow nasal cannula meets or exceeds that baby's inspiratory flow demand, and therefore they can breathe shallow and they can breathe super fast, and it's not going to affect how much oxygen is going in, because no matter what, we're exceeding their demand. Compared with the low flow nasal cannula up here, if that baby starts breathing really fast and really deep, right, really fast, really deep, then their oxygen that they're breathing in will get diluted by entraining room air, right? So any type of device that's high flow, especially these heated high flow cannulas, really make sure that their vent pattern, their breathing pattern, doesn't affect how much oxygen we're delivering, so it doesn't change. So let's say we have a baby that's breathing really, really fast on a low flow nasal cannula, so we turn up the flow rate because their SATs are starting to drop, and then their respiratory rate slows down. Well, what happens now to the amount of oxygen that they're getting? It increases, and that could cause oxidative injury to that baby. So be careful, right? Be very, very careful there. Enclosure systems like the oxygen hoods, I use those. Closed isolettes, we don't really use that feature much anymore, but that means we can control the oxygen, temperature, and humidity. So usually the isolettes will do the temperature and humidity part of this, but the oxygen hoods are still in use somewhat today. So we just got to make sure we're measuring the oxygen concentration at the level of the baby's mouth and nose. Because oxygen can layer inside these things, whether it's a hood or a tent or anything like that. Variable systems, like we talked about, nasal cannula, just depends on the baby's entrainment and how much and how deep they're breathing, right, their respiratory pattern. So babies, even on super low flow rates, can still get 24 to 45% oxygen, depending on their flow rate and their pattern. If a baby has a nasal obstruction, like a choanal atresia, trauma, something like that, obviously then we're not going to be able to give them that low flow system. Tender grips or neo holds, those things, be careful when you're removing them. A lot of time there's removing tabs for these or removing substances for these that will help, so that way we're not taking off skin layers with these babies. So be very, very careful, right? These devices can usually be stuck on their skin for 1 to 3 weeks, even during baths, right? So those are pretty sticky devices. So that's why it's not good just to go in there and rip them off, right? Don't, no, their skin's really, really soft and sensitive. So make sure that we're using the appropriate ways to take off those. Right, and here's some pictures of, these are the big dots up here, then here are the tender grips, and then here are the strips down there, the neo hold. So those are the little things that we use to keep the cannula on. Notice that these are things that will help keep that on. Now, can they come off at inopportune times? Of course they can. But the big thing too, if you're helping send a parent home with these, is teaching them how to apply them and how to use them, and making sure that they're comfortable with the procedure of putting their cannula back in there. What about blenders? So blenders really help. So there's two methods for doing low flows through a nasal cannula. You can have a cannula to a blender where it's just providing low flow to give them sort of stimulation to breathe. I haven't seen that too much in my practice, but yours may vary. Most of the time, if we take them to low flow, we're going to an 100% gas source, and that's this next bullet point here. That's usually when we'll take them to 1/32 of a liter, or 1/4 of a liter, or so on and so forth, right? So really, really low flow rates, but at 100% of the source gas. So they tend to be more stable when using lower flows, when we're using 100% source gas. So a low flow meter, or low flow Thorpe tube, or board-on gauge really helps give them that proper amount, and that's where you'll send these kids home on 1/64 or 1/32 of a liter. Hardly anything, but it's enough to keep them in the right position. So one flow rates can range from anywhere from 0.1 to 3 liters per minute, and then their increments are also very tiny too. Like I was saying before, nasal cannula, depending on how big it is and how much FiO2 you're running, can give them various flow rates that can cause them to get up to 95% inhaled oxygen. Right? That's quite a bit. But remember, they're obligate nose breathers, and it just depends on the prong to nair size and then your flow rate that you're picking. So that's going to be pretty important to make sure. There is a approximate FiO2 calculation here that I put in there for fun. I won't expect you to recall that, but I think it's kind of interesting to see all the factors that go into it, including minute ventilation, right? Minute ventilation is going to be one of your biggest ones. How fast that kid's breathing. If they're breathing less per minute, then their FiO2 will go up, right? If they're breathing more, then their FiO2 will go down, right? And so that's just showing you, hey, if this baby starts breathing really, really fast, they might desaturate. If they start slowing their breathing down, their sats might actually go way up, right? So that's just showing you that relationship. Blenders. I love these things. So blenders, or oxygen proportioning devices, is what the NPS exam calls them. If you take that credential, awesome, do it. I love that credential. But oxygen blenders, it connects to a 50 psi gas source of both oxygen and air, and it controls FiO2, and you guys have played with this in class. The big thing here, why do we want to control FiO2? And you should answer, because we don't want to avoid oxygen injury and stress to these babies, right? So the blenders are going to be helpful. What does it mean if it's alarming? If you hear this high-pitched squeal, check this blender, check the sources. Is the air and oxygen turned on or plugged in? If they're not, or they run out of gas, then that's why it's squealing. When you hear it squeal, it's called the reed valve alarm. It's a question on the NPS exam, and it's the reed valve. It means there's unequal pressures in the oxygen proportioning device, the blender, right? There's unequal pressures, so it means you either ran out of gas or you're disconnected somehow. Something like that's going on. So fix that, right? I know that on firsthand because of my first daughter's delivery. That was a good time. All right, what about things like simple mass, right? Now we're above neonates, right? Now we're in infants, toddlers. We're getting older kids here. But infants and children who need moderate concentrations, these are okay for emergency stabilization, maybe even post-anesthesia, right, type thing. So you're not going to see this too much. Mostly your PACU type situations is where I've seen it the most. Not for infants or small children with low or precise concentrations. Take note of this last part here. Right, not for infants and small children with low or precise concentration. So, hey, if a kid's just desaturating post-anesthesia, they extubated, and we're just trying to get them to wake up and give them some oxygen until they wake up, it's a good one. But other than that, no. Right? What about anything with the reservoir, like a non-rebreather, like this wonderful image of this patient? So, not really well tolerated by most infants and children, of course. This person does not look too happy to be wearing this or that their picture is being taken, but usually it's limited to short-term, like I said, situations. That means just high FiO2 until they pretty much wake up from anesthesia or until we get something in their system, right? So big thing here is you can't make it humidified either. That's going to be another thing that can be hurtful to these kids. So a flow rate, make sure you use a flow rate and able to keep that bag fully inflated during inspiration. So anywhere between 6 and 15 is appropriate for pediatric patients. And this one can deliver up to 90% for these patients. It just depends on which device, which version of this device you're using. But the breathing pattern is a lot less influenced by the FiO2. The FiO2 usually is very consistent with these reservoir devices compared to low flow ones. High flow nasal cannula, one of your most common pediatric equipments that you'll be seeing. It's still newer with the information that we're talking about with it, but the big thing here, it's been very favorable having humidified high flow nasal cannula or even the Vapotherm, which has high velocity, right? Which is a difference. The high velocity is like a super soaker that's motorized versus a garden hose that's just throwing lots of water, but not at a high velocity, right? So there's a difference with how much force is going through the lung, the nasal oropharynx, right? Going through there. So high flow oxygen or high velocity have been shown to be very cost efficient and helpful and very well tolerated to most pediatric and neonate patients. One of our favorite things was taking a baby to heated high flow after we extubated because that they were tolerating it usually quite a bit more than going on nasal CPAPs for most part. But the advantage here with nasal high flow cannulas is they give you warm humidified gas, and then it inhibits anything that causes bronchoconstriction. So therefore it prevents their increased air resistance that could be triggered by breathing in cold air, and it washes out a lot of the nasal pharynx dead space. It flushes some of the CO2 out. So their dead space to tidal volume ventilation is much more advantageous. Right, and here's pictures of the Vapotherm, and we have one of these in the lab that you can play with as well. But here you see the temperature, right? You see the temperature right here. You see the oxygen. You see the flow rate, and then this is with the Vapotherm. It does the high velocity, and it's gonna, like I said before, it's like having a garden hose that's just open versus putting a very constricted nozzle at the end of the garden hose. That nozzle that constricts the flow really makes it high velocity and helps flush out that CO2 more efficiently. So it can help their CO2s better as well if we do the high velocity component. The other advantage here, this is baby on a CPAP machine. Now, different CPAPs look different nowadays, but here you see all this equipment just to put this baby on CPAP. That's a lot of stuff, and then developmentally, that's a lot of sensory information to that baby. It's a lot of potential for skin breakdown. It limits our ability to really see and care for that baby as well. So you can see an advantage of high flow versus something like CPAP if they can be well managed with their A's, B's, and D's on high flow versus CPAP. So high flow, it provides optimal humidification, so make sure you're using it with hydration, right? It's got to be humidified. It's not approved as a CPAP delivery system. Now, it does deliver a amount of CPAP, and usually it's around 3 centimeters of water pressure, give or take, on average when they check esophageal pressures with humidified high flow systems. But the whole point here is not to give CPAP. The whole point with high flow is to flush out CO2, to flush out dead space, not to provide CPAP, right? So it can give good oxygen percentages, and then we can make sure low flow, usually around 1 to 8 liters per minute. High flow, 5 up to 40 liters per minute with your adult patients or bigger patients. So the big thing here is you're attaching it just like a regular nasal cannula. It's just a larger bore, and then make sure it's humidified for sure, and that's going to help with patient toleration. And these are just sort of your flow rates to start off with. When we're talking about kids at 14 years old or older, then you can use more. Obviously, in the little guys, you're going to use the lower flow rate, but pay attention to your hospital's policies and procedures when you're doing this, as well as making sure you're doing what's appropriate for the patient. So make sure you're also evaluating them before you start turning up flow rates or playing with it even more. Oxygen hoods, I love these. These were something I used quite a bit. They might or may not be out there in clinical practice as much anymore. But the big thing here, it's that little transparent glass thing in here. It's usually plastic nowadays, but transparent enclosure that's used. It looks like a little bit of box, or it looks like a little bit of like a space helmet, right? And you do a heated aerosol to this back part. You see this arrow, right? So you do a heated aerosol to that back part, and then you hook the venturi up, you close it, so the source gas then is from the blender. And so you use the blender to control the FiO2 instead of the venturi, because you're trying to avoid a bunch of noise with these little guys. And so you get that heated aerosol tubing, the gas fills that area around the kid's head, and then it's neutral thermic, right? And so the flow rates should always be greater than 5 liters per minute. 5 liters per minute. 5 liters per minute should be greater than, right? 5 liters per minute. Hopefully you wrote that down or put it in a note somewhere. Because anything less than that, just like a simple mask, they can retain a bunch of CO2 in that oxy hood, right? So it can just keep that CO2 in there. So there's got to be enough flow rate to the hood to wash out any CO2 the baby's breathing out. Just like a simple mask on an adult. You don't go below 5 liters because they would retain CO2, right? The temperature is maintained as close to body temperature, but the big thing, that's why I said if you put a heated aerosol on there and you help those kids. So just watch out. You have to put the some sort of device in there, right? So an oxygen analyzer at or near the level of the mouth and the nose to make sure that kid has the adequate FiO2 delivery. I know, here's some different versions here, but this is one down here of doing oxygen delivery. That dog does not look happy. All right, here's another pediatric picture, right? I love this one. And here you see oxygen probe here, right? This is that FiO2 device. And you see how it's elevated? It's not laying down. It's elevated, and it should be at the same level as her mouth and nose. And that's going to allow them to figure out, okay, as we know oxygen layers within this box, so that's going to help us determine what FiO2 she's actually inhaling. All right, that's your oxygen stuff. Medications. We have many different types of medications that you'll see, so let's get started. Beta 2s, primarily used for bronchodilators. They can be shown to increase mucociliary transport, and there's evidence to support that, so that's why you might see them as part of an airway clearance regimen. Commonly used, albuterol, levalbuterol, also known as Xopenex, or even tributylene. So levalbuterol and albuterol would be your albuterol would be your regular dose. They might half dose these, they might not. Depends on the hospital's policy and procedure. So what about vasopressors in the NICU? So vasopressors, they increase heart rate and or increase blood pressure, right? So they increase heart rate, or they increase blood pressure and or increase blood pressure. So if we have a baby that's shocky, right, a baby that has low blood pressure, low heart rate, could we give them epinephrine? Could we give them dopamine? Could we give them dobutamine? Yeah, absolutely. Those are all things we can do to help with their perfusion, so that way they don't go into multi-organ system failure. Anticholinergics, these will block the cholinergic receptors that cause bronchoconstriction. So there are side effects here. they could have some mucus plugging issues, especially in the neonates. Big thing here would be Atrovent. Atropine is rarely used here unless it's symptomatic bradycardia, and then we're using it as an IV medicine, right? So atropine we're not typically nebulizing to the baby population. However, Atrovent we could, but however it could cause mucus plugging, which is a bigger deal in neonates because of their smaller airways. So they might do Atrovent times 3 doses and then discontinue. So it's one of those drugs that we use very infrequently currently as of this recording. Xanthines, oh my goodness. So these are your number 1 treatment for apnea prematurity. So they are the primary, right? Apnea prematurity. They excite the central nervous system, the respiratory system, the cardiac system, the GI, as you know. Have you ever drinking a lot of coffee and had some GI motility afterwards? There you go. So very commonly used, theophylline can be used in your asthmatic COPD patient population, but in the neonate population, that's where we bring in the caffeine. Surfactant, obviously, we can use it either prophylactically as within that first 15 minutes of age, or we can go ahead and use it in a rescue format. So therapeutically, what we're looking at here, if they have signs of RDS or surfactant deficiency, or if their surfactant's been inactivated by some reason or another, like meconium aspiration syndrome, pulmonary edema, or prematurity, if they start to develop signs of RDS, that's where we could go ahead and have an indication for surfactant replacement therapy. Less than 32 weeks of 1,300 grams used to be according to AARC clinical practice guidelines. If their LS ratio is showing immature lungs, or their PG is showing absence of PG, which would be mature surfactant. So those are all things we can use to consider this therapy. The outcomes from surfactant replacement therapy we talked about earlier in the course, that usually lessens the severity of RDS and increases compliance. As compliance increases, you should have better ventilation, and you should have a lot easier time oxygenating, especially if you're ventilating better, right? You see how these are related. You can usually oxygenate better once you ventilate better. Yeah, go figure. Nitric oxide. This is a common drug that we use. It's a pulmonary vasodilator, or realistically, it's an endothelium-derived relaxer. So it doesn't just like Atrovent, it's not a bronchodilator. It blocks the bronchoconstriction things, but it does cause bronchodilation, right? So same thing here, right? The big thing here, it's something your body naturally creates as a result of injury. It allows for blood and nutrients to go into the tissue, right? You roll your ankle at Zumba class, right? It allows blood and nutrients to go into the tissue around the ankle to help start to repair and get the good stuff in there, right? So it's something your body naturally does, but it helps vasodilate or relax, if you will. So indications for use when we're giving it, even though it's something your body naturally creates, but we can augment it in these cases. If there's premature pulmonary hypertension of the newborn, if the baby's in respiratory distress syndrome, especially if they're acidotic and hypoxic, acidosis and hypoxemia cause pulmonary vasoconstriction. So if we give them a pulmonary vaso relaxer, right, then that's going to help with that perfusion relationship in the lungs. Just like adults with ARDS, we're going to go ahead and increase that perfusion through their lungs if we give them a pulmonary vasodilator. A meconium aspiration syndrome, sepsis, pneumonia, a congenital diaphragmatic hernia, they don't have a lot of surface area, so what can we do to get more oxygen into the bloodstream? We can increase the surface area of the bloodstream, right? We can pulmonary vasorelax, right? Or vasodilate, if you will, if your brain works better that way. There you go. Usually we'll start at 20 parts per million, and then we'll titrate down from there. So big thing here is to be careful with nitric dioxide, which is the NO2. So that means when you get into a shower, when you go to shower, do you just step into the shower and turn on the water, or do you turn on the water first, let the cold water purge, and then get into the shower. Of course, you let it purge. So with the classic Ionomax nitric delivery, make sure that you purge the nitric dioxide first. So that happens when nitric oxide is stagnant, usually greater than 5 to 10 minutes or so. It's stagnant and it combines with oxygen and forms nitric dioxide. So make sure you purge the nitric dioxide first before you start it on a baby or an adult. Right, here's a picture of what they look like here. Now there's a new system that's out there, so just pay attention to those when they come out. Mucolytics. All right, so increases mucociliary clearance and decreases the thickness of the mucus. So if you have very thick mucus, especially in the neonate population, the preemies, they tend not to have a high mucin content. So therefore, most of the time, it's their mucin, their thick mucus is caused by a lot of DNA connections, which means pulmozyme would be the drug of choice, or DNase, or right, so Dornase alpha. So that's the one that you probably will see most up in the NICU. Traditionally, this is nebulized with a vibrating mesh nebulizer. It depends what your hospital has. Make sure that you also know that this drug is kept usually refrigerated as well. So make sure that you understand it could cause bronchospasm in a baby, right, because it's cold. And so make sure that's appropriate too. And don't mix this with other drugs either. I know you're busy, I know you want to save time on stuff, but this is not a drug that you should be mixing around because it can change the chemical composition very easily when you start mixing other drugs with it. Other medications that you will see, AMP and GENT, these are antibiotics that we can give, nystatin, especially if the baby is developing thrush. You'll see that on their MAR. So I encourage you, when you're out there for the NICU rotation, look at the medications, all the medications the baby's getting, not just the medications that the respiratory therapist might be giving, because it helps give you an overall picture of what that baby's going through. Bicarb, traditionally this would be more IV. We don't usually nebulize this anymore. Once upon a time they would nebulize this for very thick airway secretions. However, it has been shown to be very damaging to lung tissue, so please avoid that. Morphine, of course, for vasodilator. Sometimes they'll use this for end-stage COPDers, right? They'll nebulize it, but this would be more of an IV medication situation here. Fentanyl and Versed, sedation, analgesia. Ativan, the most common sedation thing that you'll see out there in the NICU is going to be Ativan, right? Ativan, it's usually a PRN Ativan. We don't like to use sedation or paralytics unless we absolutely have to, especially messing with these kids' premature brains. So Zantac, obviously for reflux, Regulin, GI, heparin. If we need to Lasix, a diuretic, especially after we give blood. So if we gave blood, usually they'll do a Lasix dose after that because that baby could become hypervolemic, and that will help regulate that. Other than that, they might do a low diuretic, which if they're on caffeine, that counts as a cheap diuretic. But if they're doing aldactazide, we've already talked about that, which is a potassium-sparing diuretic, that could easily help the kid pee off fluid, and also it has anti-inflammatory properties that could help with their RDS if they already have that. So look at diuretics we could also be giving. Decadron, which would be steroids, controversial, and you'll have to talk to me later about that. I don't have enough time to lecture about the controversy behind giving steroids to a newborn, but there is controversy there. And we can talk about that separately, but you could see them give steroids if their RDS is severe enough. PGEs, right, to help close or keep open their shunt, right, their patent ductus arteriosus. So Indocin, PGEs, either to keep it open or close it, or Indocin to close it. Obviously, those would help close their patent ductus arteriosus, hopefully. All right, what about airway clearance? Postural drainage, not something we traditionally do on the newborn. Remember, this is also not just a NICU, neonatal ICU, but a neuro ICU as well. Chest percussion, not something that we do. where we do the palm cups or anything like that. Most of the time, we're going to use a vibration device, and they make special baby vibration devices out there, pediatric ones. So you'll see those, but that's percussing that chest wall, and it's moving the secretions, so babies will like that. The older children could stand chest percussion, and adults could, but there are other airway clearance methods out there too, like the therapy vests and things like that as well. Suctioning, what are some indications for suctioning your babies? Traditionally, secretions are going to be one of your biggest things. Oxygen desaturation, if they start to desaturate or they start to Brady, right? I've seen this with many kids in the NICU where they start to Brady, and then sure enough, you see a little bit of mucus in their tube. Just suction that out of the tube real quick, and usually you're good to go. High PIPs if they're on volume targeted ventilation. If they're on low, if they're in pressure control ventilation, which is what you'll see a lot of out there as of this recording, then you'll see their tidal volumes on average be a lot lower as well. Breath sounds really decrease, or even if they're on high frequency oscillator, there's something called chest wiggle factor, right? CWF. If you see less chest wiggle factor, right, that could be a sign they might need suction, or that might be a chest wall. They might have something blocking that gas from going in and out. Suction catheter size. For the tube size, of course, this breaks the rule of the ×3 divided by 2 French catheter to make sure you're using less than 50% of the patient's airway. So understand these babies could desaturate even more than what adults do with suctioning. So it doesn't mean that you just go ramp up their FiO2 every time you go to suction. Usually we pre-ventilate. So when you're doing this, you got to make sure that if a baby has issues with suctioning procedure, could we go up by 5% or 10% to pre-oxygenate during suctioning? Yes, you could, but it also might mean we could make sure that we're using intermittent suction as we apply suction, or turning down our suction pressures, things like that, to help avoid those side effects of suctioning. Deep suction is not an option. Don't do it. Right, you're just equating, you're not going past the end of the ET tube, right? You can easily go through and perforate a kid's airway if you go past the tube. Don't deep suction. Don't. All right. Levels of NICU, we've talked about this in one of our previous case studies. You should be aware of this, especially when you're going out for clinicals. What level is that site? A level 1 usually are your healthy full-term babies, right? They can transfer to different facilities if they need more advanced care, like CPAPs or anything like that. Level 2s are usually greater than 32 weeks. They're usually recovering from serious conditions, right? They can be at a level 2. These are going to be your preterm to late preterm kids. Level 3s means you can get babies usually 28 weeks. I know less than 32 weeks, so usually it's 28 weeks or so is the lowest most level 3s go. They will usually ship anything 28 weeks or less. They'll get out to a level 4, right? So anything less than 32 weeks can be at a level 3. They can be very sick. We can give them a lot of big range of things. We'll have a neonatologist available. We'll have a lot of respiratory support, advanced imaging support like echoes, things like that. But a level 4 is the highest level of NICU. That means there's going to be surgeons there. There's going to be a lot of issues that they can take care of, all the congenital heart defects, all those things. So they'll have pediatric anesthesiologists on site, right? And they'll have the ability to transport or get babies in. They'll do education and research, right? They'll even teach parents basic CPR for their babies, right? So understand your levels. So transport, when we're looking at transport, the goals of the transport team are to have a quick response and assess and stabilize that baby, right? Because they're not going to usually take a baby that's not stable. Interference with staff or interface with staff is something that they have to be very careful of. If they shame the staff if you end up working transport and you shame the staff, how likely are they to call you back to that hospital for another baby? Well, what does that mean for that next baby? That next baby won't get the care they need, and they might actually pass away because you shamed the staff last time you were there. So you're not there to shame, you're there to stabilize and get the kid out of there, so help you, right? So transport as quickly and as safely as possible. That includes safety for you as well, if you're the transport therapist. You do need to be able to make independent clinical decisions, right? So you got to have good developed skills in this area. So I don't recommend this early on, but recommend it after you've developed these skills. You got to be very, very high functioning in very unfamiliar environments. Noise, heat, cold, different areas, long flights, changing pressures, right? There's a whole bunch of physical stress that these transport therapists undergo, and you have to function at a high level. So keep that into consideration. The big thing here is you're there to provide the best care possible. As a new grad, do you think this is going to be really one of your best places, right? Make sure you get your good assessment skills under you first. Ground transport, an advantage, you don't need a landing site compared to air transport. It's better in inclement weather when it's snowing or windy or anything like that's going on. You have a large work area, larger I should say. There's a lot less noise and vibration. You can pull over, stabilize a kid. Big disadvantage is also traffic. Weather and traffic can still be an issue on these patients' transports. Helicopter are also known as rotor wing. So if you see rotor wing out there, that's what they mean by helicopter. And that's one thing that you do have a faster transport than ground transport, and it does not require a runway. It can land just sort of right on top of the hospital landing pad, wherever that may be. Big disadvantages: high noise. A lot of weather could ground it, especially if it's high wind or weather, right? Any other type of weather. Lightning will interfere with the pilot, and the work area is much smaller. You got to be very well trained. It's very expensive, and you will undergo, like I was talking about earlier, with hypobaric effects on both the patient and the equipment, the ventilator. You got to know your stuff very well. So make sure you're a good master at this. I'm not saying don't ever do it. I'm just saying if your plan and your goal is to go down this route, work at it. Right, very small loading site, very hard to get into. Here you even see the nitric tank, right? You see the nitric, and then here would be the ventilator down here, right? If you can see my arrows, right? You see the ventilator down there, and the baby would be in this thing here. So small environment, tight space. You got to have really good assessment skills because you can't be listening to breath sounds. You can't do all that. So feeling their respiratory motion, right? It's going to be very tight, very, very high stress environment. Fixed wings, this would be like your jet advantages. They can go a long way in a short period of time. So you can go across state lines. You can go to rural areas really, really fast, less vibration and noise than a helicopter or rotor wing. You can travel over inclement weather as well. But disadvantages here. You have to land at an airport and then take ground transport over to the hospital. You can be still grounded even with the fixed wing, right? Very small work area still. Altitude effects can still be on the patient and you, and it's also obviously expensive. So be careful with the positioning because their blood pressure can change with how their baby or the adults or whoever's in there is positioned. And then make sure that you adjust your FO2s and your tidal volumes and your cuff pressures appropriately when you're doing these types of things. All that comes into factor. Skills of the team, you have to be able to identify high risk factors. You have to be trained very well in NRP and stable, right? You make sure that your skills are ready to go. You might have to put in umbilical lines. You might have to do arterial lines. You might have to do so on and so forth. Chest tubes, right? You might have to do very high level skills. Are you prepared? Are you ready to do that? I'm not saying don't. I'm just saying just be prepared to do those things. You got to be able to assess gestational age. You got to have that high scope and high training. Treating the babies on your own independent decision making as part of that care team. Emotional support for staff and families is a big one, which I wish I had more time to talk about here. And then even recognizing and responding to the physiological experience of transport, because that's going to be one of the tougher things, is knowing what happens to your ventilator tidal volumes, what happens to your cuff pressures, what happens to pneumothoraces, what happens to all these things. Be ready for that. And I'm not saying you can't do it, you just got to be ready for it. Equipment for transport, obviously way more than what I could list here, but you got to have your transport isolate, ventilator, IV, suction equipment, monitors, oxygen, and equipment. So make sure you have enough oxygen to get you to and from wherever you're going. Blood pressure cuff, Doppler if needed to check pulse, right? Resuscitation equipment, intubation equipment, vent circuits, CPAPs, blood gas equipment, lab equipment, drugs, a whole bunch more. Survival stuff, right? If you guys crash somewhere, right? There's a lot of stuff that goes into this. So understand that equipment training is also going to be part of that skills development as well. All right, so here's a picture of just some of the basic things that you'll see here. Obviously an older picture, but here you see the ventilator over here you see the nitric, here you see the lab equipment, you see the transport bag and oxygen, you see the baby here and the isolate, right? You're going to see a whole lot of different things, and it's very dynamic, right? Very dynamic, but just make sure you're prepared and ready to go. All right, don't forget your duration of flows, especially depending on what your transport device has. That can be very difficult to remember, so make sure you have enough oxygen to get there and back.